First of all, I would like to welcome Dr. Gajendra Todakar. He is from Karnataka. He is also from Ayurveda fraternity, and presently he is Deputy Medical Superintendent and Administrator. He is since 2017 NA BH Principal Assessor and Faculty of NABH. We welcome you, sir. Next, I would like to welcome Mr. C. Venugopal. It's very honor to us welcoming you, sir. He is appointed as advisor in QCI, Quality Council of India, since July 2023 till date. We welcome both of you, sir, today's program. അതുപോലെ എല്ലാവരെയും ഈ ചടങ്ങിൽ ഇന്ന് എത്തിച്ചേർന്ന് ആയുർവേദ ഹോസ്പിറ്റൽ മാനേജ്മെൻറ്റ് അസോസിയേഷൻ അംഗങ്ങളെയും മുഴുവൻ ഈ പരിപാടിക്ക് എത്തിച്ചേർന്ന ഓരോരുത്തരെയും HMAക്ക് വേണ്ടി സ്വാഗതം ചെയ്യുന്നു.
കേന്ദ്ര ഗവൺമെൻറ് ക്വാളിറ്റി കൗൺസിൽ ഓഫ് ഇന്ത്യയുടെ ഏറ്റവും പ്രഗത്ഭരായ രണ്ട് എക്സ്പേർട്സാണ് ഇവിടെ വന്നിരിക്കുന്നത്. അപ്പോൾ ഓരോ നിമിഷവും ഇവരുടെ ക്ലാസ് നമ്മൾ പങ്കെടുക്കുന്നതോടൊപ്പം തന്നെ അത് നമ്മുടെ ജീവിതത്തിലും പ്രാക്ടീസിലും പകർത്താൻ വേണ്ടി കൂടിയാണ് ഇത് നമ്മൾ ഉദ്ദേശിക്കുന്നത്. ആയുർവേദ ഹോസ്പിറ്റൽ മാനേജ്മെൻറ്റ് അസോസിയേഷൻ കേരളത്തിൽ നേരത്തെ പറഞ്ഞതുപോലെ തിരുവനന്തപുരം, എറണാകുളം, അതേപോലെ മലപ്പുറം, കണ്ണൂർ ഈ 4 ഏരിയയിലും നേരത്തെ തീരുമാനിച്ച മാതിരി വളരെ നേരത്തെ തന്നെ ഹോസ്പിറ്റൽ മാനേജ്മെൻറ്റ് അസോസിയേഷൻ സ്റ്റേറ്റ് കമ്മിറ്റി തീരുമാനിച്ചത് അതിൻ്റെ രീതിയിലാണ് 2 ദിവസം 2-3 ദിവസം ഇത്തരം പരിപാടികൾ സംഘടിപ്പിക്കുന്നത്. ഇതിൽ നമ്മൾ ഉദ്ദേശിക്കുന്നത് ഒന്ന്, വടക്കൻ മേഖലയിൽ ഈ ആയുർവേദ ഹോസ്പിറ്റലുകൾ, കോട്ടക്കൽ ആയുർശാല അല്ലെങ്കിൽ ഒരു വൈദ്യശാല അല്ലെങ്കിൽ അതുപോലെ കുറുമത്തൂർ ആയുർശാല അല്ലെങ്കിൽ ഇങ്ങനെ നമ്മുടെ ഓരോ ഹോസ്പിറ്റലുകളും വളരെ നന്നായിട്ട് പ്രവർത്തിക്കുന്നുണ്ടെങ്കിലും അവിടെ ചില കാര്യങ്ങളിൽ കൃത്യമായ ഒരു ക്വാളിറ്റി കൺട്രോൾ നടപ്പിലാക്കാൻ കഴിയുന്നില്ല എന്നത് നമുക്കെല്ലാവർക്കും അറിയാവുന്നതാണ്. മാത്രമല്ല നമ്മുടെ ജീവനക്കാർക്കുള്ള ട്രെയിനിങ്, അതേപോലെ തന്നെ പഞ്ചകർമ്മയിലും മറ്റുള്ള അഡ്മിനിസ്ട്രേറ്റീവ് ലെവലിലൊക്കെ നമുക്ക് സ്വീകരിക്കേണ്ട പരിപാടികൾ, ഇതിലൊക്കെ NABH അക്രഡിറ്റേഷൻ അടക്കമുള്ള, അതായത് സ്മോൾ ആൻഡ് ടൈനി സെക്ടറിലുള്ള ഏറ്റവും ചെറിയ, അത് ഒരു 2 ബെഡ് മുതൽ മേലോട്ടുള്ള ഓരോ ഹോസ്പിറ്റലിലും ഇത് എങ്ങനെ ഉപയോഗപ്പെടുത്താമെന്നും അതിൻ്റെ എവറി ന്യൂക്ക് ആൻഡ് കോർണറിൽ നമുക്ക് എങ്ങനെ ശ്രദ്ധിക്കാമെന്നും ഉള്ള കാര്യങ്ങൾ വളരെ മൈക്രോസ്കോപ്പിക് ആൻഡ് മൈന്യൂട്ടായിട്ട് ഞങ്ങൾ പറയുന്ന ഒരു നാനോ ലെവലിൽ തന്നെ നമുക്ക് പറഞ്ഞുതരാൻ വേണ്ടി ഇവിടെ വന്നിരിക്കുന്ന നമ്മുടെ ഡോക്ടർ വേണുഗോപാൽജി, അഡ്വൈസർ NBQP/QCI പിന്നെ മാനേജർ, ഞാൻ നേരെ സംസാരിച്ചിരുന്നു, വന്നതുകൊണ്ട് തന്നെ നേരത്തെ ഇവിടെ എത്തിയിട്ടുണ്ടായിരുന്നു. അതേപോലെ തന്നെ ഡോക്ടർ ഗജേന്ദ്ര തോദാക്കർ, ഡെപ്യൂട്ടി മെഡിക്കൽ സൂപ്രണ്ട് KLE ആയുർവേദ ഹോസ്പിറ്റൽ. ഇവരുടെ ഓരോ ക്ലാസ്സും നമുക്ക് വളരെ ഉപകാരപ്പെടും എന്ന് മനസ്സിലാക്കിക്കൊണ്ട് നമ്മൾ ഇതിൽ ഹോസ്പിറ്റൽ മാനേജ്മെൻറ്റിൽ ഫസ്റ്റിൽ ഈ മാനേജ്മെൻറ്റ് ചിലപ്പോൾ ഡോക്ടർമാരായിരിക്കണമെന്നില്ല, അഡ്മിനിസ്ട്രേഷൻ അല്ലെങ്കിൽ ആ ലെവലിലായിരിക്കണമെന്നില്ല, എങ്കിൽ പോലും പല കാര്യങ്ങളിലും നമുക്ക് ശ്രദ്ധിക്കാൻ കഴിയാത്തത് കൊണ്ട് തന്നെ നമ്മുടെ രോഗികൾക്ക് മാത്രമല്ല ഈ പറയുന്നത് വിഷമം വരണ്ട, ഈ ഒരു ട്രേഡ് യൂണിയൻ മാഫിയാണ് അല്ലെങ്കിൽ ഒരു ടെററിസമാണ് പലപ്പോഴും നമ്മൾ അനുഭവിക്കേണ്ടി വരുന്നത്. അത് ജീവനക്കാർക്ക് വേണ്ടി മാത്രമൊന്നുമല്ല, നമ്മൾ നല്ല ക്വാളിറ്റിയുള്ള അല്ലെങ്കിൽ വളരെ എക്സ്പെർട്ടായ ജീവനക്കാർക്ക് വെച്ചിട്ടുണ്ടെങ്കിൽ പോലും ഇവരുടെ ചില പ്രശ്നങ്ങൾ കാരണം നമുക്ക് അവരുടെ മുഴുവൻ കഴിവുകൾ ഉപയോഗപ്പെടുത്താൻ പറ്റുന്നില്ല. അതേപോലെ തന്നെ ഡോക്ടേഴ്സ് ആണെങ്കിൽ കോഴ്സ് കഴിഞ്ഞ് പുറത്തിറങ്ങിയ ഉടൻ തന്നെ അവർക്ക് മറ്റ് പല മേഖലയിൽ നിന്നും, അതായത് ഡിഗ്രി ഇല്ലാത്ത ഡോക്ടർമാർ അതിൻ്റെ കീഴിൽ വർക്ക് ചെയ്യേണ്ട ഇതുവരെ വരുന്നൊരവസ്ഥ, അല്ലെങ്കിൽ അവർക്കാണ് മേൽക്കോയ്മ എന്ന് നമ്മെ ഭരിക്കുന്ന ഗവൺമെൻറ് വരെ, അല്ലെങ്കിൽ മന്ത്രിയും മുഖ്യമന്ത്രിയും അല്ലെങ്കിൽ അതിനേക്കാൾ മേലുള്ള ആൾക്കാരും വരെ പ്രചരിപ്പിക്കുന്ന രീതിയിൽ ഡോക്ടർമാരുടെ ഒരു കോൺഫിഡൻസ് ഇല്ലാതാക്കുന്ന ഒരു സംവിധാനം നമ്മുടെ നാട്ടിൽ വന്നിട്ടുണ്ട്. അതുകൊണ്ട് തന്നെ നമുക്ക് നമ്മുടെ നാട്ടിൽ പ്രൊഡക്ഷൻ ലെവലിലാണെങ്കിലും സർവീസ് ലെവലാണെങ്കിലും നമ്മുടെ ഇതുവരെ കൊറോണയ്ക്ക് മുമ്പുണ്ടായിരുന്ന നമ്മുടെ പ്രവർത്തന പരിപാടിയും പദ്ധതികളും ഈവൻ നടത്തിപ്പ് പോലും 50% ബാക്കോട്ട് പോയിരിക്കുകയാണ്. അപ്പോൾ അതൊക്കെ ഇനി നമുക്ക് വീണ്ടെടുത്താൽ മാത്രമേ നമുക്ക് ആയുർവേദ മേഖലയിൽ വർക്കുന്ന ആൾക്കാർക്ക് ഒരു ഒരു സാറ്റിസ്ഫാക്ഷനും അതുപോലെ തന്നെ ഈ ക്വാളിറ്റി കൺട്രോളും മറ്റുള്ള കാര്യങ്ങളൊക്കെ നടത്താൻ പറ്റുകയുള്ളൂ. അതിനുവേണ്ടി അഹോരാത്രം പ്രവർത്തിക്കുന്ന നമ്മുടെ HMAയുടെ സ്റ്റേറ്റ് കമ്മിറ്റി ഓരോ മേഖലയിലും അതിനുവേണ്ട രീതിയിലുള്ള സൗകര്യങ്ങൾ സംവിധാനങ്ങൾ ചെയ്യുന്നുണ്ട്. അതോടൊപ്പം തന്നെ ഇന്ന് ഈ പരിപാടി കഴിഞ്ഞ ഉടൻ തന്നെ ജില്ലാ കമ്മിറ്റികൾ ഒന്ന് കൂടിയിട്ട് ഇതെങ്ങനെ നടപ്പിലാക്കുമെന്നും ഇതിൻ്റെ ഒരു വാട്സപ്പ് കൂട്ടായ്മ ഉണ്ടാവും. NABHന് വേണ്ടിയിട്ടൊക്കെ അപേക്ഷിച്ച് കാത്തിരിക്കുന്ന ഒരുപാട് സ്ഥാപനങ്ങൾ ഇന്നിവിടെ വന്നിട്ടുണ്ട്. അവർക്കൊക്കെ വേണ്ടി നിങ്ങൾക്ക് ആവശ്യമുള്ള ഒരു ക്വസ്റ്റ്യൻ ആൻസർ സെഷൻ കൂടി ഉണ്ടാവും. അതുകൂടി സംഘടിപ്പിക്കുന്നുണ്ട്. നിങ്ങൾക്ക് എന്തെങ്കിലും പ്രതിബന്ധങ്ങൾ, പ്രയാസങ്ങൾ അല്ലെങ്കിൽ ആവശ്യങ്ങളുണ്ടെങ്കിൽ അതുകൂടി ചോദിച്ച് തീർക്കാമെന്ന് അറിയിച്ചുകൊണ്ട് ഇതിൻ്റെ ഉദ്ഘാടനത്തിന് വേണ്ടിയിട്ട് നമ്മുടെ ബഹുമാനപ്പെട്ട സ്റ്റേറ്റ് സെക്രട്ടറി ഡോക്ടർ ഇടൂരി ഉണ്ണികൃഷ്ണൻ സാറിനെ ക്ഷണിച്ചോളൂ.
ഈ ക്വാളിറ്റി ജേണിയിലേക്ക് ആരൊക്കെ ആഗ്രഹിക്കുന്നോ അവരൊക്കെ ഈ യാത്രയിൽ കൂടെ കൂട്ടിക്കൊണ്ട് മുന്നോട്ട് പോകാനാണ് 2012 മുതൽ since 2012 onwards in one of our state conference we have held on this topic of NABH in 2012 onwards, and last I think in Palakkad we have conducted an interactive session with NABH director Poonam Bajaj madam started, and she came and she interacted with the stakeholders members, and that was a confidence making program. And after that program, number of hospitals, that is from micro to small level hospitals, are very eagerly looking for the quality journey towards the NABH and QCA. And it was the concept that a small hospital cannot attain these kind of achievements. So certain standards we have. That's why HMA from initial stage onwards we were requesting that an entry level. Previously it was not entry level, only HCO complete accreditation. And entry level is needed. Many member hospital can enter into this quality journey. And now I can proudly say that there are 353 Ayush hospital. Out of them 25% are from Kerala, and that is due to the activities related with HMA and these kind of QCI and NABH the associationship. So even a clinic or a Panchakarma center can improve their standards and services. നമുക്ക് അറിയാം, ഇന്ന് ആയുർവേദത്തിനെതിരായി ശക്തമായ പ്രചരണം കേരളത്തിൽ നടക്കുന്നുണ്ട്. കാരണം ശുദ്ധ ആയുർവേദം തീർച്ചയായും പ്രൊമോട്ട് ചെയ്യപ്പെടുന്ന ആയുർവേദത്തിൻ്റെ ഈറ്റില്ലം എന്ന് പറയുന്നത് കേരളമാണ്. അതുകൊണ്ട് തന്നെ ആയുർവേദ മരുന്നുകൾ കഴിച്ചാൽ, ആയുർവേദ ചികിത്സകൾ ചെയ്താൽ പലതരത്തിലുള്ള ബുദ്ധിമുട്ടുകൾ ഉണ്ടാവുന്നുള്ള രീതിയിൽ സോഷ്യൽ മീഡിയ പ്രചരണങ്ങൾ ഏറ്റവും കൂടുതൽ നടക്കുന്നു. ഇത് നമ്മുടെ ഇൻഡസ്ട്രിയെ ബാധിച്ചിട്ടുണ്ട്. അവിടെ നമുക്ക് കൊടുക്കാവുന്ന ഒരു ഉത്തരം എന്ന് പറയുന്നത് നമ്മൾ എത്രത്തോളം സ്റ്റാൻഡേർഡ് ആണ്, എത്രത്തോളം നമ്മൾ ഇതിൽ തന്നെ എങ്ങനെയാണ് നാഷണൽ ഹെൽത്ത് കെയർ സ്റ്റാൻഡേർഡ്സ് നമുക്ക് മീറ്റ് ചെയ്യുക. അതിനാദ്യം നമ്മൾ ഈ മേഖലയെക്കുറിച്ചിട്ടുള്ള ഒരു അറിവ് കൊണ്ട് നമ്മൾ ആ നോളജ് കൊണ്ട് നമ്മൾ എംപവർ ആവണം. കാരണം പല കാര്യങ്ങളും ചെറിയ ഹോസ്പിറ്റലിനും നമുക്ക് നേടിയെടുക്കാവുന്നതേ ഉള്ളൂ. ആ ഒരു സ്റ്റാൻഡേർഡ് നമ്മൾ NABHൻ്റെ ഒക്കെ എൻട്രി ലെവലിലോ അല്ലെങ്കിൽ തന്നെ അതിൻ്റെ ഫുൾ അക്രഡിറ്റേഷൻ ലെവലിൽ സർട്ടിഫിക്കേഷനും ഉണ്ട്, അക്രഡിറ്റേഷനും ഉണ്ട്. ഇതിലൊക്കെ വന്നാൽ പലതരം നമുക്കിപ്പോൾ പല ക്ലെയിമുകളായാലും മറ്റു പല ഇതിനും നമുക്ക് വളരെ ഈസി ആയിട്ട് കാര്യങ്ങൾ ചെയ്തു പോകാൻ വേണ്ടി സാധിക്കും. Another one of the requests from our association side, sir, we need an SSCO category to put in the Ayush sector, because in modern sector we have SSCO and it's entry level category. The same scenario is existing in Ayurveda sector also. So there are 90% of hospitals. There are 750 hospitals in Kerala. Out of that 90% are under 50. Means 0 to 15 bedded hospital. That is very micro level hospital. We cannot make a full accreditation of this one. So for that, it's our humble request that if you can initiate a talk in your board meeting and all regarding SSCO category in Ayush sector also. It's an entry and this one we will be it will be highly appreciated, sir. It is a request from the stakeholder association, and many in Kerala. Then I can surely say that I think 2-3 years back we met with Adul Kochar sir, CEO of NABH, and he made an umbrella, and he told that if you can come to our umbrella, we can make a difference. The same thing happened in Kerala. Many, even in Wayanad 6 hospital achieved NABH accreditation. In Kannur recently, Dr. Satyagopal sir's hospital, Dr. Prabhanj Aptashri hospital, 2 hospitals. Because of this initiation only, we have started. In Kasaragod also, some are waiting for the application and all. So we think that after this interaction, we can have more number of hospitals in this quality journey, and we are making the impression that everybody can achieve these standards, because it is now Ayurvedam ഇന്നിപ്പോൾ ഒരു ഗ്ലോബൽ സ്റ്റാൻഡേർഡിലേക്ക് എത്തിക്കൊണ്ടിരിക്കുകയാണ്. അപ്പോൾ നമ്മുടെ പലപ്പോഴും നമ്മുടെ ഡൊമസ്റ്റിക് ആയിട്ടുള്ള ആൾക്കാർ, നമ്മൾ മെഡിക്കൽ വാല്യൂ ട്രാവലിൻ്റെ ഒക്കെ ഭാഗമായിട്ട് നമ്മുടെ അന്യ സംസ്ഥാനത്ത് നിന്ന് കണ്ണൂരും കാസർഗോഡും വയനാടും ഒക്കെ നിരവധി പേര് വന്നെത്തിക്കൊണ്ടിരിക്കുന്നുണ്ട്. അതുപോലെ വിദേശ രാജ്യത്ത് നിന്ന് ഇപ്പോൾ ആയുഷ് വിസ വന്നിരിക്കുന്നു. ആയുഷ് വിസ വന്നത് വഴി നമുക്ക് കൃത്യമായിട്ട് കൂടുതൽ ആൾക്കാരെ അതിലേക്ക് എത്തിക്കാൻ കഴിയും. അതിലൊരു വിഷയം ഉണ്ടായ ഉടനെ തന്നെ FRRO ഓഫീസുമായി ബന്ധപ്പെട്ട് HMA ഇടപെടുകയും ടൂറിസം മിനിസ്റ്ററുമായി ഈ വിഷയം സംസാരിക്കുകയും FRRO ഓഫീസിൽ നിന്ന് ഇതിന്റെ നിയന്ത്രണം നീക്കുക. എത്രയോ നമ്മുടെ നാട്ടിലെ ഹോസ്പിറ്റൽസിന് അതുകൊണ്ടുള്ള ഗുണമുണ്ടായി.
See, QCI started something called as Gunavatta Yatra. In simple English is not our language, but to translate that as a quality journey. So they started this quality journey in the month of February across India, across each district, major cities, and they're aiming for pin code level. Now they have 4 stages to go. I will come later why it is required. Now 4 stages means the first one is Yatra. Yatra means we know only Kashi Yatra, these things, but this is a quality Yatra. This is something very different. Even I was not knowing about this. Yatra is also like this. So quality Yatra means we will just as a tourist, what you call as Yatrik, we go to each city, each district, and spread awareness about quality standards, healthcare standards. Earlier saints were there. I don't know whether this generation knows about it. Saints used to roam across India, they used to go in a bare feet to spread something, a good knowledge, good practices. Same concept has been adopted by QCI now. Let us go every part of the country and let us do some benefit to the citizens of this country, whether it is the health sector, whether it is the manufacturing sector, whether it is a testing, whether it is a software testing, whether it is a dental clinics, Ayush centers. So they took up this initiative and they started something called as Gunavatta Yatra. So the main reason is to help healthcare facilities like Ayush centers, Ayurvedic hospitals to achieve NABH accreditation and to enhance their service quality and also to meet national healthcare standards. We have all international standards, but India is promoting now we are not less than anybody in the world. So we are going towards Viksit Bharat, that is developed nation. We are going to that direction. So for that we should have our own standards. Everybody should follow our own standards. So in this context, the Yatra is started. The second phase is going to be handhold the clinics, Ayush centers for entry level or hospitals for accreditation. Because it is simply, giving awareness and, go back, no use, because they listen and what to do next. Somebody has to come and help us to come into this system. So that is a second stage where NABH or QCI is going to do that. So for that, QCI is planning to have our own QCI nominated a kind of consultant okay, not a private bodies. QCI is going to develop that. So the hospital or anybody, no need to pay a single paisa to that particular consultant. QCI is going to depute that particular persons to your hospital clinics. That is the second way of doing it. The third they are planning is to make a consultorium of Ayush centers or experts, like medical experts. So each discipline they are going to do a consultorium wherein maybe some representative like Dr. Unikrishnan we will pick up, or maybe Dr. Prapanch will pick it up. Okay, you may be in the main body of the consultorium, wherein each state will have each consultorium and they will be helping NABH in formulating the standards, spreading the awareness programs, helping the hospitals. So that is the third level they are going into it. And the fourth level is, now AHMA, yesterday we were in Kottakkal and today we are in Kannur, next week we are in Trivandrum, and next Monday we are in Kottayam. Now this is not the end with AHMA. So we want to do programs till this end of year with AHMA, every district, every taluk level. Maybe we may not be having such kind of, in a hotel or anything. Our plan is to go a small place, a small, camp, like, maybe put a small shamiana and, make one awareness program. Let all the villagers, these people come and assemble there. And we are going to explain what is the importance of Ayush practices, why it is required, what is NABH, all this. So these 4 level QCI is planning it. So this is the first stage we have started now. So for this, I think I should thank all of you, all the way coming, that too in the afternoon, so to listen to us and making this particular initiative taken by Dr. Umeshji and Unikrishnan and all of you to attend this and making this program successful in AHMA Kannur chapter. So with this small introduction, I don't want to go into QCI because everybody knows about it, and sir also you will explain due to these time restrictions. So I will end my talk here.
But a doctor, he has missed the signs and the symptoms of that girl, and this he has not examined it properly. Okay, so based on that he prescribed few medications, but she died on the same day in the night. So here, see, abdomen, the cavity, it's about 300 cc blood present. Even liver hematoma, kidneys hematoma. See, around 300 cc of blood is collected in her abdomen. Each and every organs are also a hematoma. Okay, even the bladder is also, it's a hematoma present. So how the doctor missed this kind of thing, like because of lack of initial assessment, appropriate initial assessment he has missed. Okay. Lack of accountability. See, unattended for hours, 2 die at the same hospital, like KEM hospital. Because in NABH we should understand the initial assessment has to be completed with a time frame. For example, a new patient come for the registration, then from the registration till he exits from the OPD, that's we call it as an initial assessment time. So that time we need to fix for outpatient, and we need to fix for inpatient, and we need to fix for the emergency patients. So for outpatients, generally within half an hour the initial assessment has to be completed, right? For the inpatient, generally it's a 2 hours, within 2 hours the initial assessment has to be completed. For the emergency, is there any timeline for emergency patients? For emergency patients, whenever the patient arrives, immediately the initial assessment has to be completed. There is no time limit for the 2 hours, 3 hours for the emergency patients. Okay. So like that, in NA-based, we need to define time frame for initial assessment of the patients also, for outpatients, for inpatients and the emergency patients. So here it's lack of accountability that they have not properly defined and they have not implemented this process. And also if it's a case of mass casualty, for example, 1 mass casualty, like for example any accident, so 10 injury patients they have come to your hospital. So in that case also we need to go for triage. What do you mean by triage? TRIAGE, triage. Triage means sorting, okay, based on the condition. If the patient is very serious, we need to attend immediately. The patient is not so much serious, then we need to attend later part. So priority wise we need to categorize. Priority 1, that we call it as a red. Priority 2, it's yellow. Priority 3, green. Priority 4 is black, right? So based on that we need to categorize all 10 patients and we need to attend those who are need medical attention immediately. Okay, so that's the whole idea about the triage decision. It is holds good in the mass casualty. If 1 or 2 patients, then you can attend the patients, but if it is more than 5-6 patients, then we call it as a mass casualty. Then this triage decision holds good in that situation part. Plus the issues why these are called hospital acquired infections. For example, if the bed sore patient, okay, if the bed sore patient already the patient had a like bed sore, he admitted in your hospital. So if the bed sore condition was worsened after 72 hours, then it is considered as a hospital acquired infection, right? If there was no any bed sore, but the patient admitted into your hospital, after 72 hours, if the patient developed a bed sore in your hospital, that is also we need to consider as a hospital infection, acquired infections. Okay, so if already the patient is having a bed sore, after admitting in your hospital, after 72 hours, if the bed sore condition is worsened, then we need to consider it as a hospital acquired infections. So a number of hospital acquired infections are there, so that we need to capture and we need to take appropriate actions to control such hospital infection, acquired infections. So needle stick injuries, generally needle stick injuries will be happening during the phlebotomy and all. So we need to train the lab staff, safe practices, how we need to go for safe practices and all. So there is a training for needle stick injury and the body or body fluid exposure management. These trainings we need to provide to the lab technicians. Misguiding the patients about costs. See, generally for the patient we need to explain about the estimate cost for about if the patient is undergoing for some 7 to 8 days treatment. So we need to explain we need to educate the patient and the family members about the estimated cost. So here for the appendectomy they are charging 1,10,000 rupees, right? So that also it's matters. So we need to explain the patients, that is misguiding. This is unethical prescriptions, what we understand, because there is something called rational prescription. Okay, while writing the medicines also we need to understand the cost of the medicines also. Okay, and whether these medicines are useful to that particular patient or not. We should not randomly, we should not write any medications which are not required for the patient also. So this is a prescription. It's about 42 medications. It's not a full prescription. It's a half prescription. This is a complete prescription. 57 medicines for one patient. It's only for one patient, not a family. It's for the patient, for one patient. Okay. So 57 medicines are written, and this is one more prescription for one single patient. So this we
for 1 year.
that too all basmas, right? So this kind of unethical prescriptions we should not allow also in the quality part. So there should be a rational prescription, right? So we need to understand the requirement of the patient, and also we need to think on the cost of the medicines also. Okay. Assault on doctors and hospitals. See, if we practice as per the standards, then you can avoid such incidents also. Okay. So based on these points, is it not necessary to regulate and monitor the healthcare organization? So over exploitation of the patient, as you seen that misguiding of patient about the cost, then misguiding the patient, unnecessary medicines, investigations, hospitalization. The patient doesn't require hospitalization for such treatment. Still the doctors are forcing them to get admit in the hospital. Okay. Ill-equipped hospitals, inadequate and ill-trained paramedical staff, patients not getting value for their money also, right? So based on this, who will bell the cat? Is there any certification body with no commercial interest and who accredits purely on merit? Is there any system to validate the claims made by an ICE center in order to safeguard the interest of patients? Is there any organization with well qualified and well groomed medical professionals as assessors? Is there any organization which defines and validates different aspects of the healthcare organization? Is there any organization whose stamp of approval is recognized and respected across the globe? Is there any organization which believes that the quality system is quite adoptable even by ICE systems and is making sincere effort for the same? Which is the organization? Yeah, under QCI, the NABH is doing all the things. So because the NABH doesn't have any commercial interest and accredits the hospitals or the healthcare organizations or the centers or the clinics purely based on the merit, right? So it's about NABH. The NABH, National Accreditation Board for Hospitals and Healthcare Providers, it's a constituent board of Quality Council of India. So Quality Council of India is having 5 boards. So under that, NABH is one among the Quality Council of India. So NABH was established in association with the Government of India and Indian health industry in 2005. And 2006, the first accreditation standards for hospitals were launched for the allopathy actually. And 2010 expanded its wings to international accreditation like Afghanistan, Bangladesh and Bhutan. The vision and mission of NABH, basically the vision of the NABH is to be Apex National Healthcare Accreditation and Quality Improvement Body. Basically it's a healthcare accreditation and quality improvement body, and the mission is to operate accreditation and allied programs in collaboration with stakeholders focusing on patient safety and quality of healthcare and self and external evaluation based on the through a process of self and external evaluation. Basically it's about patient safety and the quality care. Okay. So NABH objectives, the 3 major objectives of NABH are enhancing the health system, promoting the continuous quality improvement. Third is about the patient safety. Okay. These are the 3 main major objectives of NABH, and the components of NABH are structure, process, outcome. See, with an example, a new patient. Okay, so new patient while entering into your hospital, what he expects? Basically a patient, new patient entering into your hospital, what he expects? Whenever the new patient comes to your hospital, you wanted to know whether what are the services are available in this hospital and what are the services are not offered by the hospital, and what is the OPD timings, okay, and where is the registration counter, okay, where is the reception counter. So we need to have a scope of services, display, signages, that we need to go here for the registration counter, reception counter and all. So when the patient enters into a hospital, then he wanted to know some more information about the hospital. So he will visit the registration counter or the reception counter, and reception counter staff should able to explain about what are the services available in this hospital, who are the doctors are available, okay, what are the timings and all. So that will be explained to the patient, and patient wanted to register himself, so he will go to the registration counter. So in the registration counter, the staff will ask about the personal details of the patient, and she will fill in the system, and she will generate one number. That number is called hospital, like UHID number, unique hospital identification number. Okay, then some registration fees will be there, so that number, that fees will be paid, and the receipt will be handed over to the patient, and then patient will goes to the, and the registration staff will direct the patient to go to screening OPD, where the medical officer will be there. So there the medical officer will take some history and complaints and all, and then the patient has to wait for 10 or 15 minutes for the consultation of the main chief physician. So for that, the patient requires sitting arrangement, right, chairs and all, then fan, drinking water facility, then toilet facility and all. Then once it's clear, then the patient goes into a OPD for the consultation. There the doctor will ask again, thorough examination he will do, and then prescribe the medications. If not, if only medications, or they will prescribe for the investigations also. Then the patient will purchase the medicines and he will exit from the hospital, right? So this is like one new patient. Whenever the patient enters into your hospital, this is the process what he undergo. So the structure means here the displays, the scope of services display, the signages, registration counter, reception counter, the sitting arrangements, chairs, fan, water facility, drinking water facility. These are all called as structure. And the process is, when the registration starts, like she will take details of the patient, then generates the UHID number, then the registration fees, receipt handed over to the patient, and ask the patient to go to OPD, there the initial assessment. This is all process, okay? And the outcome is, outcome will be two things. One is the patient needs hassle-free services, and second is about the result of the treatment. If the patient is if the patient is satisfied with the services as well as the treatment, then obviously the outcome will be good, right? So that is how we need to understand structure, process and outcome. Outcome will be last, but structure and process goes hand in hand. Okay, always structure and process goes in hand, whereas at the end there will be a outcome. Okay. So benefits, basically the patients are the biggest beneficiaries of accreditation and the certification, because they will be they will get services by the credentialed medical staff. Credentialed medical staff means who are qualified, who are verified by the staff about their qualifications. Okay, so we are get a service by the credentialed medical staff, and also rights of patients are protected and respected, because we need to have some rights, patient rights we have, and that has to be protected. Okay, so for that reason we need to provide training to all the categories of staff with respect to the patient rights and the responsibilities, because everyone should know about the patient rights, because the thing is we should not violate the patient rights. If we violate the patient rights, even the patients can sue you in the court of law. Okay, so each and every categories of staff should know about the patient rights. So healthcare organization, obviously it stimulates the continuous improvement. If once the hospital gets accreditation, so it stimulates for the continuous improvement, and also it's demonstrating commitment to quality care, and also the staffs who are there in the accredited hospital will be satisfied because of continuous learning. Good working environment will be there in the accredited hospital. So that's the benefit to the staff also, and it improves overall professional development for the clinicians as well as the paramedical staff. Okay, so once you practice, like whenever you document in the case sheet, there are 4 things we need to do. One is signature, name, date and time. These are the 4 things we need to document in the medical records. So when whoever will document, like for example, one chief physician documents in the case sheet. So below that, signature, name, date and time. These are 4 things are mandatory whenever you document or whenever you do entries in the medical records. So even that much of professional development will be there. Even when they go for the restaurant, when the waiter will give the bill for the signature, even for that also we'll put signature, name, date and time. So that much of culture we need to develop. Okay, like how we after food we drink a water, obviously. So whenever we document or whenever we do entries in the medical records, we should go for sign, name, date and time. Driving factors for accreditation, generally we are come under the Consumer Protection Act, Clinical Establishment Act, insurance companies regulation, even the medical health tourism. These are the driving factors why these hospitals should go for accreditation or the certifications. NABH program and other activities. NABH operates the following programs like accreditation. They are into accreditations and certifications and training and education, and also empanelment. Okay, empanelment for CGHS, ECHS also. And other accreditation or certification programs under this NABH. Hospitals and small healthcare organization is for the allopathy, and blood banks and the centers, dental facilities also, Ayush hospitals, even full accreditation, and Ayush entry level for hospitals as well as for the centers, and allopathy clinics, Panchkarma clinics. Even recently we have digital health standards also, and eye care organization. Eye care organization is for only for allopathy hospitals. And NABH standards, we have 27 standards. There are separate standard booklets are available in the NABH. So if you want a hard copy from the NABH, you need to pay a reasonable amount of fee, and then you will get a hard copy. Otherwise, it is a downloadable format. You can have a soft copy also. It's free of cost. And NABH Ayush programs, accreditation program for hospitals, especially for the Ayush, they have started in the year 2009. Okay, under this is for full accreditation. Okay, so Ayurveda standards for hospitals, yoga and naturopathy standards for center, Unani standards for hospitals, Siddha standards for hospitals, homeopathy standards for hospitals. This is about accreditation programs are about full accreditation. Okay. And accreditation program for Panchkarma clinics, there is a separate standard which was launched in February 2017. So that is for exclusive for Panchkarma clinics. And entry level certification program, it's for Ayush entry level certification program for hospitals and centers. The standards were launched in the year 2019. Okay. For entry level standards for hospital, Ayush hospitals, and entry level standards for Ayush center. Okay. And now for 500 plus Ayush hospitals are accredited. 2000 plus assessments have been conducted till date for the Ayush health and wellness centers under the NAM project. Even 1430 plus Arogya Mandiras are certified under the NAMH project. This is new Ayush accreditation standards. NABH accreditation standards for Ayush hospitals. Ayush hospitals in the sense, the hospital which are having a services of Ayurveda, homeopathy, Unani, yoga and naturopathy, okay, or Siddha. So if they have multiple disciplinaries, then you can apply for this NABH standards for Ayush hospitals. If it's for Ayush treatment and wellness centers, if the hospital is having a wellness like spa and all, so they can go for this NABH standard for Ayush treatment and wellness centers. This is new standards where recently the NABH were launched. Ayush standards. So for full accreditation, the 98 standards and objective elements 590 and 10 chapters. Yoga also 51, 505 and all, like Panchakarma clinics we have 52 standards and 225 objective elements and 10 chapters. So basically there are 10 chapters for the NABH. Okay. Only for centers we have 8 chapters. That is certification. Ayush hospital we have 37 standards, objective 146 and the chapters are 10. Ayush center first edition, that is 29 standards and 140 objective elements and 8 chapters. So obviously full accreditation means 98 standards, whereas for the entry level it is about half, like 37 standards are there. For Ayurveda hospitals, minimum 10 beds are required. Okay. Yoga, naturopathy are also centers, and Unani, Siddha, homeopathy, all like for full accreditation, minimum 10 beds are required. And for the entry level, for the hospitals, minimum 5 beds are required. Hospitals as well, for full accreditation, we have 10 chapters. First 5 we have focused on the patient-centered standards, and next 5 are organization-centered standards. Okay. First 5, why we call it as a patient-centered standards? Any idea? Basically, these 5 chapters are focusing on patient-related aspects. Okay. For example, AAC, it involves about the registration, admission process, initial assessment, laboratory, imaging, discharge summaries, discharge process. Second, care of patient, it's about the pediatric patients, how we care for the obs and gynec patients, how we care for vulnerable patients, how we care for surgical patients. So that is comes under the care of patient. Management of medication, it's about the procurement of medicine, storage, medication, dispensing, prescription. Patient rights and responsible education, it's about the patient rights and responsibilities and informed consent aspects. So those come 4th chapter. Fifth is hospital infection control. That is the infection control, how we need to control, what are the things we need to do, what are the standard precautions we need to take care, what are the meaning of hand hygiene part, guidelines and all. So that is, so basically it is related to the patient side. Okay, so patient centered standards. Organization centers, it's about the managerial aspect. Okay, CQI, continuous quality improvement. We need to capture the data, quality indicators. Okay, how many missing records. Okay, those things are under this CQI. Responsibility of management regarding the licenses, registrations. Okay, and governance about of the hospital comes under the responsibility of management. Facility management and safety, it's about the biomedical equipments. Okay, about the water management, after electrical management aspect. Okay, these engineering controls, those are comes under the facility management, safety, even fire thing, safety aspects. Human resource management, it's about the recruitment of the staff, training and development, appraisal system, disciplinary actions. So those comes under this HRM. Information management system, it's about the medical records, storage, retention period for the medical records, destruction of medical records. Those comes under the IMS. So here basically these 5 chapters are organization centered or the managerial centered. Okay. See, this is first chapter, like in access, assessment, continuity of care. It includes about the scope of services. Means in your hospital, what are the services are available and what are the services are not available. That should be displayed. Okay, and first you need to define and then display it. And this display, all the signages or the any displays, it should be bilingual. Okay, bilingual in the sense one in English, one in local language. Need to have some external assurance program. We need to have that. We need to send the same sample to other laboratory, and we need to check with the results whether the same results are coming or not. Okay, then imaging and the imaging services, it's the same, like if you have any X-ray and all, so the quality assurance about the accuracy about the results. Okay, and also the safety aspects, safe practices like the aprons, lead apron and all, so those things will come under the imaging services part. Referring, if you want to refer the patient to the other center, so there should be some, you need to give referral slip to the patient. Okay, so those comes under the referral aspect. And even the discharge process, how we need to go for discharge process, how we need to coordinate with other departments during this discharge process, and the content of discharge process, because we need to provide discharge summary to all the admitted patients. Okay, so here what will be the content of discharge summary? Because you need to provide discharge summary to all the admitted patients. So what will be the content of the discharge summary? Headings, such care. What do you mean by vulnerable patients? Basically, vulnerable group of patients means elderly. We need to define, like if above 75 age, we will consider them as a vulnerable. Children, okay, mentally retarded, physically challenged patients. Okay, those are, we need to consider them as a vulnerable patient, because we need to we should identify vulnerable patients, and we should give or provide a special care to such patients. Okay, for that reason only in toilets and all, or in Panchkarma, we need to have grab bars. Okay, and for the bed, we need to have bed rails. Okay, for the wheelchair and for the stretcher, we need to have a safety belts. Okay, for these are the patient safety devices. So especially that will be applicable for the vulnerable group of patients. We call it as a LASA medications, look-alike and sound-alike. So as per the guidelines says, these group of like LASA medications we need to store separately. Separately means why it is important? Because the medication errors may happen because of storage of LASA medications. Okay, so appropriate LASA medication should be there. So how it has to be stored? Most of the hospitals, what they do, they will identify the look-alike medications, but between two medications they will keep one card sheet that they will tell that we have kept separately. Okay, so to avoid, keeping in mind, like we need to avoid medication error. So for that purpose, how we need to store the look-alike medications? Okay, for example, if this medication is look-alike with this particular medicine, then we need to keep, generally we need to keep those medications diagonally. So one medicine will be in this particular shelf and one medicine will be below, like diagonally. Okay, so that is the how ideally we need to keep the storage of the LASA medications. Even same applicable for the sound-alike medications also. Same diagonally we need to keep. It is not like keeping one here and keeping another look-alike medication here and keeping one card sheet. It is not advisable, because obviously it may like the staff or the pharmacist who can pick either this or this also. So those portalies and all, so where we need to dispose and all, so those things should come in the biomedical waste aspect. Okay, otherwise it will be simply a whole thing will be of allopathy only, but we are generating different waste, so that we need to understand and we need to include in our policies or the manuals. Okay, continuous quality improvement, it's about the quality indicators aspect. So important thing is quality indicators. As we said, if there is a missing record. For example, there is one quality indicator called percentage of missing records. Okay, what do you mean by missing records? Missing records means whole case record will be missed, or a single page of the medical records, if it missed, that is also missing record. Okay, so for that purpose we should understand, whenever there is a submission of the medical records to the medical record department, we should understand how many pages are there in that particular medical records. Okay, so for example, consents will be single pages, but whereas the progress notes of the doctors will be 4 or 5 pages. So we need to have some checklist kind of thing, like parameters like the forms available, not available, or not applicable, and number of pages. Okay, so that if total pages are 30, then when we submit to the MRD staff should also ensure that these are 30 pages. Then they can keep in the MRD. So that is how it has to be done. If, for example, in our hospital, 10% of missing records every month. Okay, that is the, you need to, for each quality indicators, you need to fix one target value or benchmark or threshold value as a 10%, because average is 10%, so we need to fix that 10%. Once you achieve 10%, then you need to bring down that 10% to 8% and implement some strategies to achieve 8% of missing records. Once you achieve 8%, bring down that 8% to 5%, then 3%, then 1%, then 0. So like that, few quality indicators you need to bring down from the 10-20% to 0, and few indicators you need to bring up from 90% to 100%. For example, patient satisfaction. If it's 80% is the average patient satisfaction, then you need to bring put a benchmark about 85%, then achieve that 85%, then bring up from 85% to 90%, 95%, 100%. It is not like for 1 month, next month only we should achieve. It's not like that, as it's a continuous quality improvement. So it will take another 1 year, 2 years to achieve 100% also. So like that, we need to have list of clinical quality indicators and managerial quality indicators, and for each indicators we need to have some targets. Then only it will be helpful for the further improvement aspect. It's about the governance of the part, like responsibility management aspects. So especially focusing on the statutory documents. Okay, statutory documents, basically 5 important documents are required for NABH. One is hospital registration. Second is about fire document. If it is fire NOC is applicable, you need to have a fire NOC. Otherwise, the third party detailed audit report you need to have. And the pollution control board consents. If it's a big hospital, then you need to have a consent for air and water, and also the biomedical waste authorization. Okay. Now in Kerala, they are giving integrated consent for even for biomedical waste authorization as well as the air and water. And one more is the agreement, MOU, biomedical waste MOU. Okay, these are the 4-5 documents are required for the NABH especially. So how we need to ensure?
Regarding the hospital registration.
Yes, sir.
I think here there are 2 types of registrations. One is issued by Panchayati or state autonomous body, and second is the clinical
Establishment.
Yeah.
Yes,
So
sir.
what is the basic requirement of NABH to?
See, basic requirement, there are 2 things, sir. Both the things are required. One is local registration is also required, and if the Clinical Establishment Act is enforced in the state, so that is also required. Now they are providing a provisional certificates, so that is also considered. And how?
Provisional certificate is acceptable to you?
Yeah. Because 4 years they will give.
Provisional certificate for a span of 5
4 years. 4 years. Yeah. Earlier in the
What
Gazette.
year they are supposed to issue the final certificate, because if I am submitting the entire document for the registration, and how they are having this a span of 4 years. to issue
Actually,
the-
it was 2
the
years.
provisional
Yes, sir.
means- Provisional means they have to
Yeah,
issue the
correct.
certificate for that.
So the thing is, the clinical establishment was started in the year 2010. Okay, but this clinical establishment was not allowed to implement in all the states. Only few states are invited for the implementation of Clinical Establishment Act. So in that case, they have in the Gazette they have mentioned as a 2 years for the provisional certification part for the renewal aspect. So they are started with the provisional. Okay.
But this IRD's direction, the insurance companies are not accepting this clinical certificate. They are stressing about they are in need of hospital registration issued by the autonomous body. So there is the problem. Actually, is it necessary because we are obtaining the proper registration certificate from the and even the Panchayat is not again properly competent to check what are the minimum requirements of an hospital as far as the clinical establishment is concerned. They have the proper staff, doctors to check what are the minimum basic criteria for that. But the IRDAs and the insurance companies are rejecting this
Because of,
clinical certificate, whereas in comparison to the Italian, the issued by the Panchayat, actually they are not capable to check the basic criteria of an hospital. So it is our submission that they must accept the certificate issued by the clinical authority.
Yes,
Instead of this administrative staff of a Panchayat, which is having elected by the people, by the president or secretary, I think he is not competent to issue that certificate of an hospital. Of course, we check what are the basic criteria for a shop.
Correct.
But as far as the hospital is concerned, some medical officers, he is competent and the insurance company must accept. Subsequently, the NABH also.
Anyways, you will accept for this thing. That is not a question for the NABH. The only thing is now as Clinical Establishment Act, if wherever they in the states are there, then they have to have at least provisional certificate is also acceptable for the NABH. Equipments, biomedical equipments, equipments have to be calibrated. Generally, this calibration will be done yearly basis. So, which are in your hospital, if you have any biomedical equipments that are to be calibrated once a year. And also there should be a plan, fire, in case of fire emergency, like we need to display a fire escape routes. You are here, so where we need to go. So that display we need to have across the hospital in prominent places. Okay. And also safe, like as I said, patient safety devices we need to install across the hospital, like grab bars for the stretchers, and as well as for the wheelchairs we need to have safety belts. Okay. Then bed rails, okay. Because few vulnerable patients we need to admit on the particular cots which are having the bed rails. So like that, some safety, patient safety devices we need to install. Human resource management, it's about the recruitment policy you need to have, and for all the staff we need to maintain a personal records, that is HR files. Okay, so the content may be the resume will be there, then appointment order, joining letter, okay, credentials, that is qualification details, address details, okay, then the appraisal forms, okay. Then any disciplinary actions they have been taken, like memos and all, that has to go in the personal file. And the update of training also. So whenever the staff undergoes some particular trainings, so that training record should be in the personal file. Okay. And the annually there should be a health checkup. So that record should go in the personal file. And the privileging system or the privileging process is to be for therapists, then nursing professionals, then the doctors. There should be a privileging in the sense, if the nursing staff is having a training for CPR or BLS training, so she can be a member or she can be head of the CPR team. So like that we need to provide a privileging. The privileging will be given based on their qualification, based on their experience, based on their training, based on their skills. So, and there should be appraisal system. Generally, annually the appraisal system has to be there, like the confidential report will be taken from the senior of the staff, and then we need to give the increments and all. So that is the performance appraisal bar. And maintenance relates to safety and healthcare, health of the employees, that is regular health checkups and all. Food handlers, we need to go for stool examination is mandatory for food handlers, that too every 6 months. And for all other staff, annually health checkup is required. And IMS, it's about the medical records. What are the requirements of the medical records, means what are the contents of the medical records we need to have, and also the storage of the medical records, retention period we need to define, and also how we will issue the medical records to the patient or the attenders, and how we will destruct medical records. Okay, and also the review of medical records. Who is the owner of the medical records? Who is the owner of the medical records? Who is the owner?
The hospital is
Owner is patient is the owner of his own medical records. Okay, because we need to have a confidentiality of the patient information. So if you want to give a patient information to other body, we need to take a permission from the patient. Okay, that is, we call it as authorization letter from the patient, that we need to take. So that is a part. And review of medical records means every month we need to check for the medical records, the content, because this review of medical records should focus on 3 aspects. One is timeline, okay, timeliness, then the completeness and the legibility. Okay, so based on these 3 things we need to focus, and we need to have a checklist for such things. So why meeting compliance is important? Because safety first, as I said, it's about the providing the safety to patient, visitors and the staff, that we need to conduct a mock drills and all. And land of law, as each state has their own law, health, because health is a state law. So most of the states, like for example in Karnataka, we have Karnataka Private Medical Establishment Act. There is no any clinical establishment act. This we have. And in our Karnataka, we have 2 certificates from the Pollution Control Board. One is about biomedical waste authorization, and one is about consent for air and water. Whereas in Kerala, they will give integrated thing, and whereas in other states, they give combined consent. So like that, different states have different part. So, and quality healthcare services like timely assessment, reassessment, at turnaround time for the laboratory, that when we will get the reports, that we need to tell to the patient that after 2 hours we will get the reports. So that is a turnaround time part. Patient and employee rights are protected. Satisfaction survey based on the feedback of the patient and all, that patient safety satisfaction survey we need to conduct. Quality journey for NA-based hospitals, not a destination, as it's a continuous process. So it's a continuous quality improvement part. So there is no any destination for the quality journey. How we need to prepare for the NABH. So see, most of the hospitals, what they do is they copy other hospital documents and they do the part. Okay. So in some instance, like as we go for the assessments, so we check the checklist of housekeeping checklist, or the toilet cleaning checklist, or housekeeping. So they will mention like exhaust fan, AC. They will put tick mark daily. 1 to 31 days will be there. They will put tick mark for all the days. But the thing is, daily we can't clean the fan, exhaust fan, AC. It's not practical, right? But still there is a tick mark. Okay, and even sometimes there is no AC in that particular room, but still they tick mark. Okay, so such instance also there. So as a NA-based assessors, as we tell, those kind of checklists are, we call it as a tick list. It's not a checklist, it's a tick list. Always go on ticking. whatever the left side will be there, they won't see. Just they go for ticking. So that we call it as a tick list. Okay. The checklist importance is, checklist is one of the quality tool among 7 quality tools. Okay. In which industry this quality, this checklists are very important, or they are practicing very effectively? In which industry this checklist they are using or they are implemented effectively? In which industry? Documentation, legal compliances. As I said, statutory documents are very important. So whether they are complied, all the statutory documents or not, okay, because it takes time. When you apply for some government officials for any certification or any licenses, it will take time. So first we need to address such statutory documents part, and then training staff to all the categories of staff on NABH standards. Okay, because in NABH, whenever there is assessment, we will not ask the coordinator about to demonstrate the spillage management and all. We will ask the AYA or the Group D worker to demonstrate. So it means we need to provide the trainings to all the categories of staff or the concerned staff, so that they will be practice in day-to-day things. Okay. Otherwise, on the same day they will practice. Okay. So most of the time when we go for the assessment, each and every staff will be wearing the cap, mask, gloves every day. They are moving right place. We thought they know about the infection part. They are more cautious about the infection. They understood infection, so they are very effectively. They have implemented the infection control program in this hospital. And okay, surprisingly, even the patients are also wearing the cap and mask. Then we had a doubt that this hospital is basically they are doing for the assessment purpose only. Then we asked the coordinator, we want to see a footage of previous day. So there is no cap, there is no mask. This much of space is required for consultation room. This much of space is required for Panchkarma. These are the materials are required in Panchkarma. Earlier it was there. Now there is only one word. They tell about adequate space. Okay. So it's understood like adequate space means in the consultation room, easy movement of the doctor as well as the patient. So that is sufficient part. So adequate staff. As per requirement or workload, you can have your own staffs, like number of staffs. Training to all categories of staff, as wherever you find a word aware, familiar, orient, train. Wherever you find train, orient, familiar, aware. Wherever you find these 4 words in the standards and the objective elements, those are the mandatory training topics. The team members or all the staff should have same goal, that we should get accreditation or we should go for certification. Okay, and you need to involve senior management involved in the beginning of the process. Okay, that is also important. So designate a NABH or accreditation coordinator, and you need to have some committees also, because basically for hospitals we need to have some infection control committee, pharmacy and therapeutic committee, safety committee, quality committee and all. Few committees are required. So that committees we need to have for safety, for audits. Okay. So these few committees are required for the effective implementation of standards. And understand the standards. So first we need to understand the standards, how effectively we can implement. It's very simple. For example, there is a standard says, there is an objective element says that we need to provide a discharge summary to all the admitted patients. Then what is the evidence that we have provided a discharge summary to the patients? How it will be implemented? The standard says the discharge summary has to be provided to all the patients, all the admitted patients. Then what is the evidence that you have provided the discharge summary to the patient? What is the evidence? Signature. You will have one copy. So on that copy, received copy, if they put a signature, and then you will attach. So that's the evidence. So like that we need to understand, we need to sit back, they have to document the case has been referred to higher center. Only that sentence is sufficient in discharge summary. Whereas we are providing a referral letter, there the details, like what are things, what investigations we have done that particular patient and what treatment is undertaking. So that point should go in the referral letter. In the discharge summary also we need to provide, but whereas we need to document condition of discharge, there we need to mention the patient has been referred to higher center. And identify and address all infrastructure, statutory and legal requirements, as I said, because it takes little bit of time. So first we need to focus on this infrastructure as well as the statutory documents aspect. And then gap analysis, as I said, existing practice, you need to correlate with the standards whether we are following. If we are not following, then we need to identify as a gap and then we need to take a corrective action. Okay. Then few assessment we need to conduct as gap analysis. Met means that all the compliances you have met. Okay. Partially met means you have a documentation but not implementation, or you have implemented but there is no documentation. So that is a partial met. And no, not met means you have not touched that point only. Means for example, informed consent is to be there for the anesthesia, but you don't have a informed consent. That is not met. Okay. If partially means you have a document but you are not implemented, means no doctor is filling the form and all. So that is not implemented. So that is partially met. Met means you have a documentation also and also you have implemented that. So that is met. So in this case, you first identify the gap, then you need to focus for not met and partial met. Met already you have achieved. So you need to focus on not met and partially met. So that the sample of time frames, that is about the mapping of standards and gap analysis. It's about the thing. Procedure and procedures like policy and procedure, development of policy and procedures, you need to have some time for 60 days minimum. And there is a word called train. Okay, train all the categories of staff. The important word in NABH is train. Okay, so implement in practice, audit, gap, close the gap, then you need to go for the application part. So you need to give a target dates, then only this all the documentation will be happen. If not, if you ask some Panchkarma department to develop SOPs, if you ask this month, if you ask next month also, they will tell, yeah, we are developing, we are writing the SOPs. Next month also they will tell the same thing. So we need to give a timeline that you wish within this period you need to complete. Then only this will be achievable. Levels of documentation, external documents as statutory documents part, then records and formats and some registers are required like incident forms, reporting form, register, referral register and all. So that's SOPs, Panchkarma procedures, SOPs have to be there. So the format for SOP writing is, for example, SOP for Abhyanga, then the introduction about Abhyanga, then requirements, under requirements, manpower, okay, then the materials, then pre-procedure, procedure, post-procedure, safety precautions and emergency management. Okay, for example, John Basti, there is a burn, then what emergency management you have? So that you need to write. So first is about introduction, then requirements, under requirements, manpower and material. Third is about pre-procedure, procedure, post-procedure, safety precautions and emergency management. So and documented policy and procedures, and then lastly Apex manual. Apex manual is called as a essential document in NABH. So it contains all these documents like records, work instructions, documented policy and procedures. That's the essential document. And each document, how much detail is required? It's like if all the possible things you need to write. If it happens, okay, for example, water test report, E. coli absent, that is fine. If it is present, then what is your course of action? So like that you need to write in a document like policy or the procedures. That much of like possible things you need to write. If it happens, then what we need to do. So that is how the documentation is the required part. If is important, documentation detailing and verify that small details are right. Okay, that much of start your documentation helps stakeholders in preparation of policy and procedures, and it has to be approved by the medical director or the head of the institution that these are accurate, we can implement. Okay, then we need for the training requirements, as I said, you need to list training programs, then identify the faculty for the trainings. Okay, for it's simple, like if you are conducting a infection control practices training, then infection control committee members can take a training to all the categories of staff. Like that, you need to identify the faculties. Okay, once capturing the quality indicators and do internal assessment, that is self-evaluation, then you need to go for registration for NABH. So as I said, Ayush entry level, there are two categories, hospital and center. For Ayush entry level, minimum beds are required 5 for hospitals, and whereas center means it's about standalone OPD. Okay, there is no any IPD beds. So stages of certification, first we need to register, then we need to fill the application form. After application, fee submission, then desktop assessment, means after submission, assessment will goes to the assessor for desktop, means he will sit in home and he will review the application form. If any non-compliances, means any NCs will be raised. If the document uploaded document was not appropriate to that particular question, then he may raise the NC, non-compliances. So for that you need to prepare evidence to close the non-compliances. Again we need to submit. So like that, 2 opportunities will be given for the HCO. And after that, once satisfied, desktop assessment is completed, then you need to have a on-site assessment. Means one assessor will visit the on-site and he will verify the documents as well as the implementation part. Again, he may raise the non-compliances. Again, you need to close with the appropriate evidences. Then the case will be in the certification board or the accreditation committee. There all the members will agree that this report are satisfied, then they will issue a certification. So that's how for the certification part. Whereas for full accreditation, you need to submit application. Then earlier there was a pre-assessment system. Now it is optional. You can go for final assessment directly. Okay. So final assessment means all the assessors will come for your hospital for the assessment. Then they will raise non-compliance. Again, you need to close with the appropriate evidence. Once the assessors are satisfied, then that will be closed and it will be taken by the accreditation committee. In accreditation committee, all the members are agreed or satisfied with the report. Then they will grant accreditations and issue a certificate. Then surveillance assessment means whether hospital is still adhered with the standards or not. So in the mid of the 3 years, they will conduct one more assessment. Okay, because generally after accreditation they will close the accreditation book, and once the renewal times will come, then again they will open the book. So like that the hospitals are practicing, but it's as NABH is a continuous process quality improvement. So there will be after surveillance, after your 3 year of accreditation, then again you need to go for renewal. That we call it as a reassessment. During entire process, delegate and empower the work to the identified suitable individuals. Then have target dates. As I said, fixed target date, you need to complete this work in this particular period. Then periodic review the status of working. Prioritize. As I said, statutory documents need some time, so you need to prioritize based on the work. Awareness campaign and development the quality culture that kill the rumors that NABH is too tough. Okay, it's very easy to implement. Okay, most of the hospitals, it's a myth that there should be a POP in the OPD. It's not necessary. Okay, there should be AC in OPD. These are all myths. Okay, as assessors, we just check whether it's hygiene part, then whether they have appropriate documentation, okay, so that much, and hand washing facility is there in the OPD or not, whether there is appropriate vent area space is there or not, only that, and privacy during the exam. This only will check, will not check POP which kind of material they have used. That's not a business of the assessors, okay. So that's the thing. And confidence building, you need to have confidence building activity for the staff, and you need to prepare for change. Means there is a change management will be there. If you ask someone to come regularly, if the patient is if the staff is coming in the same way, if you ask them to come to other way, then obviously the staff will ask why. So there will be a change. So prepare for change mindset, get cooperation of all, I to us, get suggestions, and get involvement for process owners also. Journey towards healthcare excellence, establish quality system in each and every areas of the hospital. Then obviously you will accredit. Then achieve service excellence. No bossism in the NABH entire process. There should be a leadership kind of thing. No boss. Need your commitment to make a new beginning, that never doubt that a small group of thoughtful, committed persons can change the world. Indeed, it's the only thing that ever has. So, if you have few members in the hospital who are very committed and thoughtful minds, then they can easily achieve a NABH. These are the full accreditation. 3 years validity will be there. There is a category. As I said, for full accreditation, 10 beds are required. So 10 to 49 beds, one category, and there will be a application fees for one time and annual fees every year, plus 18% GST. So like that, they have made a category 1, category 2, category 3, category 4. Category 4 will be generally teaching hospitals will be there. So more than 200 beds. And annual fees every year, fees has to be paid for 3 years. And 18% GST will be there. Okay. And for full accreditation, 3 years validity for Panchakarma clinic, 1 to 5 Panchakarma tables, application fees 5,000, annual fees is 15,000. So more than 5, so that's fee, application fees and the annual fees. Even NABH or NABH is conducting a program on implementation. It's the 3 days of training period, like each chapter wise and application, how we need to fill and application, those will be taken in the program on implementation. 3 days, and it will be for closed as well as for open program also. Closed means if one big hospital wants to have this program for their employees, so that we call it as a closed. And open means NABH, they will announce this program so that everyone anywhere from the whole India can join for that program. So that is open program. So case study, generally best practices at Panchakarma Theatre. It's in our hospital, what we have done is patient satisfaction was deteriorating because of some important issue, that is generally patients are not satisfied when there is a ongoing treatment. If most of the time when the therapists are opening the door and coming, going, so that makes like patients are dissatisfied with that part. And also the patients, if the overload patients will be there, then the therapists, what they do is, if you are providing some incentives to the therapist, then they are hurry in completing the treatments. So in both the cases, the patients' satisfaction rates are going deteriorating. So what we have done is we have done a tray system for each patient. So if there is a procedure for Takradara and all, so what are the requirements for that particular procedure, we'll take in one particular tray, and once the therapist will go along with the tray, he will not come back from the therapy room until he finishes treatment. So like that system what we have developed, okay. And also the second part is it's about the intimating the procedure timing also. For example, if the timing for Abhyanga 35 minutes and Shirodhara is for 30 minutes, so In our offer, what we have done is for each therapy rooms we have displayed one time board. So there the doctor will write the timing. Abhyanga 10 start time, end time 10:35. Takradara 10:35, then 11:05 is the timing. So that the same thing will be told to the patient, and we have put one wall clock also, so that the patient should ensure that okay, this is the time what the duration of the treatment will be there. So the patient rate, like satisfaction rate, is comparatively high because of implementation of such things. These are the small things, but it makes a difference. So this is the application process for full accreditation, and ALC, Ayush entry level, it's for entry level certification part. It's a login aspect. For more information regarding NABH accreditation, you can contact. This is the address of NABH, the contact number. And Dr. Indu Bala, she is working as a deputy director NABH. She is taking care for Ayush hospitals. Okay. So if you have any queries, regarding the accreditation or the certification part, you can meet to Dr. Indu Bala, deputy director NABH. She is taking care for Ayush hospital. If you have a lift, then lift license will be there. If you have a X-ray, then ARB certificate is required. So like that, if you have a USG sonography part, then you need to have a PCP-NDT certificate. So like that it will go. But these are the 5 basic. Should not be tested with the bare hands. That's the concept. But when we go for the assessment, everyone are wearing the gloves, the plastic gloves. They are wearing for both the hands, and they are taking the bottle from the rack. They are opening, they are writing with the gloves, everything. Later they will put inside and they will take the comment and they will do it. Okay. So the understand, the thing is, the concept says we should not test the medicines with the bare hands. That's the simple. So before doing like that, then we need to, without wearing the hand gloves, we need to pick from the rack, need to open. Okay. Then at the time of touching the products of this thing, that time we can use the gloves and we can count and we can, or we can use this spoon, or we can have some measurement, like if you take 10 tablets at a time it will come. So such instruments are also there, so that you can use for the dispensing of the medicines. But everyone will tell NABH told that we need to wear gloves. It's not like that. Okay, even NABH will not tell you need to take 100 rupees as a registration fees. Okay, so NABH will give all the policy and procedures are self-explanatory. It is concerned to your hospital. NABH will not interfere in why you are taking 100 rupees as a registration fees. Okay, so it's all about self-explanatory. But in some instance, you need to follow guidelines, national and international guidelines. That is important. You can't tell that will not do hand hygiene. After touching a patient, will not go for hand wash. It's not like that. In some instance, we need to follow guidelines, wherever the national and the international guidelines are there, that we need to follow. In most of the time, we need to have some self-explanatory policy and procedures that we need to have. Hospitals wanted to go for full accreditation, but as the annual fees, like fees structure, little bit more than the entry level. So if you are not aware about most of the standards and all, then you can go for certification 2 years, then you will understand the quality part, then you can go for the full accreditation. That is also good. And most of the hospitals, it is not required that all the standards and objective elements should be implemented. If you don't have a kitchen services, you can outsource that. Okay, and if you don't have that kind of services, you need to ask for exclusion also, but with appropriate justification is needed. Okay, if you don't have any services like laundry services or kitchen services or pharmacy, then you can go for outsource also. But for outsource, you need to have some MOU. Okay, and MOU, and also you have a visit report also. Visit report means if the whole idea is why we require the visit reports. You are sending a patient to laboratory, so there also NABH expects that in their organization also, the patient should get the quality care. Okay, so such things you need to understand, and you need to go with the checklist that these are the things are required for the laboratory services. Whether they are following, then they are following means that's a visit report we need to document with that appropriate photographic evidences. If the laboratory is NABL accredited, your team is not will not go to that particular laboratory and go for checking the quality aspect because it's already NABL. Even for the emergency cases, you need to have a MOU with the allopathic hospital. If already NABH accredited hospital, then there is no question of going your team to check the quality. Just you require MOU along with their certificate, that NABH certificate or NABH certificate. That is it. In kitchen and all, you need to visit for checking out the quality aspect, and that documentation and the photographs are needed. But the only thing is in next years, coming years, probably if NABH accredited means they can hike their fees 25%. So that kind of benefits will be there for the full accreditation. But as of this thing, there is no much difference regarding the benefits for accreditation as well as certification.
I proudly take the pledge.
I proudly take the pledge.
Strive for the quality.
Strive for the quality.
In all the facets of life.
In all facets of life.
For Viksit Bharat.
For Viksit Bharat.
Promote consciousness.
Promote consciousness.
For a cleaner.
For a cleaner.
And greener.
Greener.
Quality Bharat.
Quality Bharat.
Embrace and promote.
Embrace and promote.
The vocal for local.
Vocal for local.
Campaign.
Campaign.
And support.
And support.
Indigenous products.
Indigenous products.
Fostering economic growth.
Fostering economic growth.
And self-reliance.
And self-reliance.
Commit to encourage.
Commit to encourage.
Others to foster.
Others to foster.
A culture of innovation.
A culture of innovation.
Integrity.
Integrity.
And continuous improvement.
And continuous improvement.
Thank you, sir.
Everyone tried to get this entry-level certificate or at least accreditation. So in this occasion, I just want to say thank for sirs for coming here. Actually, this initiation of taking this class is so informative. It is very important for the society nowadays, and to give them the knowledge of what NABH is. So thank you, sir, for coming here and taking the class. I thank each and every person who come here to attend the class and make this fruitful in person. And I thank our General Secretary Iduri Unnikrishnan for inaugurating the function. And thanks each and everyone. And I just want to conclude this before that. So we are going to sit now.
പല വിഷയങ്ങളും നേരത്തെ സൂചിപ്പിച്ചതുപോലെ നമ്മുടെ ലൈസൻസ് രജിസ്ട്രേഷൻ ഇതുമായി ബന്ധപ്പെട്ടിട്ടുള്ള പല സ്റ്റാറ്റ്യൂട്ടറി വിഷയങ്ങളിലും സംഘടന കൃത്യമായ ഇടപെടലുകൾ നടത്തിക്കൊണ്ടിരിക്കുന്നുണ്ട്. എനിക്ക് ഒന്നേ പറയാനുള്ളൂ, എന്തെങ്കിലും ഇത്തരം പ്രായോഗിക വിഷയങ്ങൾ ഉണ്ടെങ്കിൽ ഈ കൂട്ടായ്മയിൽ എല്ലാ ലീഗൽ കാര്യങ്ങൾ അറിയുന്നവർ നമ്മുടെ കൂടെയുണ്ട്. നിരവധി വർഷങ്ങളായി ആയുർവേദ എസ്റ്റാബ്ലിഷ്മെന്റ് നടത്തി പരിചയമുള്ളവരുണ്ട്. അപ്പോൾ ആ കൂട്ടായ്മ ചർച്ച ചെയ്തെടുക്കുന്ന പല പരിപാടികൾക്കും നല്ല സൊല്യൂഷൻസ് കിട്ടാറുണ്ട്. അതാണ് ഇപ്പൊ PCBന്റെ ഒരു വിഷയം പത്തനംതിട്ട ജില്ലയിൽ കഴിഞ്ഞ ആഴ്ച വന്നപ്പോ ഞങ്ങൾ ആദ്യം കൊടുത്തത് ഒരു ക്വസ്റ്റ്യനെയർ HMA പാസ് ചെയ്യുക ചെയ്തത്. ആ ക്വസ്റ്റ്യനെയറിൽ എന്താണെന്ന് വെച്ചാൽ നിങ്ങൾക്ക് സ്വയം ബയോമെഡിക്കൽ വേസ്റ്റ് ഉണ്ടോ ഇല്ലയോ എന്ന് ആ ക്വസ്റ്റ്യനെയർ 10 ക്വസ്റ്റ്യൻസ് ഫില്ല് ചെയ്താൽ നിങ്ങൾക്ക് തീരുമാനിക്കാം എൻ്റെ ക്ലിനിക്കിൽ എൻ്റെ ഹോസ്പിറ്റലിൽ ബയോമെഡിക്കൽ വേസ്റ്റ് ഉണ്ട് എന്നാണെങ്കിൽ നിങ്ങൾ പോകേണ്ട വഴി ഇങ്ങനെ.
ഇല്ല എന്നാണെങ്കിൽ നിങ്ങൾ പോകേണ്ട വഴി ഇങ്ങനെ. ഇത്രയും കൃത്യമായിട്ട് നമുക്ക് ഓരോ വിഷയത്തിലും, അതുപോലെ 5 വർഷത്തെ സ്വിഫ്റ്റ് വഴി ഇപ്പൊ 5 വർഷത്തേക്ക് ലൈസൻസ് കിട്ടുന്നുണ്ട്. അപ്പൊ നിങ്ങൾ നിങ്ങളുടെ ക്ലിനിക്ക് റൂമിലിരുന്ന്, ഹോസ്പിറ്റൽ റൂമിലിരുന്ന് 5 വർഷത്തേക്കുള്ള ലൈസൻസ് എടുക്കണം. പക്ഷെ നിങ്ങൾ പോയി സെക്രട്ടറിയെ കാണുമ്പോഴായിരിക്കും അവർ പറയാ ഞങ്ങൾക്ക് അങ്ങനെ ഇൻഫർമേഷൻ ഇല്ല എന്ന്. നിങ്ങൾ ഉടൻ അങ്ങനെയാണെങ്കിൽ ഒന്ന് എഴുതി തരണം എന്ന് പറഞ്ഞ് എഴുതി കണ്ണൂർ ജില്ലാ കമ്മിറ്റിയിലോ അല്ലെങ്കിൽ കാസർഗോഡ് ജില്ലാ കമ്മിറ്റിയിലോ കൊടുത്താൽ മതി. ബാക്കി HMA ടേക്കപ്പ് ചെയ്യും. കാരണം പല വിഷയങ്ങളിലും ഒരു പക്ഷേ ഉദ്യോഗസ്ഥർ കാര്യങ്ങൾ മനസ്സിലാക്കിയിട്ടുണ്ടാവില്ല. മേലെ തട്ടിൽ എല്ലാ കാര്യങ്ങളും അവിടെ കറക്റ്റ് ആയി പോയിട്ടുണ്ട്. പക്ഷെ അവയർനെസ് എമംഗ് ദ എക്സിക്യൂട്ടീവ് അത് ഉണ്ടായിട്ടുണ്ടാവില്ല. അതുകൊണ്ട് പക്ഷെ കൃത്യമായി ഒരു ഓർഗനൈസേഷന്റെ ഒരു ലെറ്ററോ ഓർഗനൈസേഷന്റെ ഇതോ പോകുമ്പോൾ അത് ക്ലിയർ ആക്കി എടുക്കും. ഒരു അനുഭവം കൂടി പറയാം. തിരുവനന്തപുരം ജില്ലയില് തോളിക്കാട് എന്ന ഒരു ഗ്രാമത്തില് ഒരു ഡോക്ടർ, കേരളത്തിലെ ഏറ്റവും പ്രശസ്തിയായ ഒരു വനിതാ ഡോക്ടർ ഒരു ആയുർവേദ ഹോസ്പിറ്റൽ ആരംഭിച്ചു. ആ ഹോസ്പിറ്റൽ ആരംഭിച്ചപ്പോ അവർക്ക് നേരെ അവിടെ എന്തോ പ്രാദേശികമായി പോയി ചെറിയ ചില കാര്യങ്ങൾ ചെയ്യേണ്ടത് ചെയ്തില്ല എന്നതുകൊണ്ട് അവരുടെ ഹോസ്പിറ്റലിന് തടസ്സം ഉണ്ടാക്കത്തക്ക രീതിയിൽ ആ പഞ്ചായത്തിലെ സെക്രട്ടറിയും ചില ആൾക്കാരും കൂടി വന്ന് അവിടെ ചെറിയ ചില പ്രയോഗങ്ങൾ നടത്തി. ഹോസ്പിറ്റലിൽ വന്ന് ആദ്യമായി, നിങ്ങൾ ചിലപ്പോ ഈ കൂട്ടത്തിലിരിക്കുന്ന ആൾക്കാർ അറിഞ്ഞിട്ടുണ്ടാവില്ല, ആദ്യമായി ഒരു ആയുർവേദ ആശുപത്രി ആക്രമിച്ചതിന് ആദ്യമായി FIR ഇട്ട്, HMAയുടെ ഇടപെടൽ മൂലം FIR ഇട്ട് കേസ് മുഖ്യമന്ത്രി DIG ഇതാക്കിക്കൊണ്ട് ആ കേസ് ടേക്കപ്പ് ചെയ്യും. അടുത്ത ദിവസം പഞ്ചായത്ത് ഡയറക്ടർ ഈ സെക്രട്ടറിയെ വിളിച്ച് ചോദിക്കുകയും ചെയ്തു. അപ്പൊ നമുക്ക് പല വിഷയങ്ങളിലും നിയമത്തിന്റെ അജ്ഞത മൂലം ഉദ്യോഗസ്ഥർ നിങ്ങളുടെ സ്ഥാപനങ്ങളിൽ കുതിര കയറാൻ വരുന്നുണ്ടെങ്കിൽ നമുക്കൊരു കൂട്ടായ്മയുണ്ട്. ഈ കൂട്ടായ്മ ഒരു 5 കൊല്ലം മുമ്പുള്ളതിനേക്കാൾ ശക്തമാണ് ഇപ്പോൾ. കാരണം എല്ലാ വിഷയങ്ങളിലും ഇപ്പൊ നമ്മൾ ദേശീയ തലത്തിൽ ഇപ്പോ ഈ രീതിയിൽ QCI ആയാലും നമ്മൾ നാഷണൽ ആയുർവേദ അക്കാദമി ആയാലും ആയുഷിന്റെ ഡിപ്പാർട്ട്മെന്റ് ആയാലും ഒക്കെ തന്നെ നമ്മൾ ചേർന്ന് നമ്മൾ ചെയ്യുന്നുണ്ട്. ഇനിയിപ്പോ ഒരു സർവേ വരാൻ വേണ്ടി പോകുന്നുണ്ട്. റിസർച്ച് ഇൻ ഇൻഡസ്ട്രിയൽ ഏരിയ ആയിട്ടൊരു RISന്റെ ഒരു സർവേ വരാൻ പോകുന്നുണ്ട്. അതിൽ ചില ക്ലാരിറ്റി വേണമെന്ന് പറഞ്ഞിട്ട് HMA ആയുഷ് സെക്രട്ടറിക്ക് ഇത് കൊടുത്തപ്പോ ഒരു ചില ക്ലാരിറ്റിക്ക് വേണ്ടിയിട്ട് ഇൻഫർമേഷൻ തരുന്നുണ്ട്. അപ്പൊ ഈ ഒരു കൂട്ടായ്മ നിങ്ങൾ ഒരു പക്ഷേ എല്ലാവരും തിരക്കുള്ള പ്രാക്ടീഷണർമാരുള്ള ഒരു ഇതാണ് എന്നുള്ളത് കൊണ്ട് നമുക്ക് കൂടുതൽ സമയം കൂടിയിരിക്കാൻ കഴിയുന്നില്ലെങ്കിലും നിങ്ങൾക്ക് ആവശ്യമുള്ള സമയത്ത് കൃത്യമായ ഇടപെടൽ നടത്താൻ കേരളത്തിൽ തിരുവനന്തപുരം മുതൽ കാസർഗോഡ് വരെ സംവിധാനങ്ങളുണ്ട് എന്ന് മാത്രം ഞാൻ ഒറ്റ വാക്കിൽ പറഞ്ഞു വെച്ച്, ആരും ഇനി ഞാൻ മീറ്റിംഗിൽ വരാത്തതുകൊണ്ട് എനിക്ക് സഹായിക്കും അങ്ങനെയില്ല. മെമ്പർ അല്ലാത്തവർക്കും നമ്മൾ വയനാട്ടില് പല വിഷയങ്ങളും നടന്നപ്പോൾ നമ്മളെ മെമ്പർമാരൊന്നും ആയിരുന്നില്ല. അവസാനം അവരെല്ലാവരും കൂടി അവിടെ ഒരു കമ്മിറ്റി ഉണ്ടാക്കി, 30 അംഗ കമ്മിറ്റി ഉണ്ടാക്കി. മെമ്പർ അല്ലെങ്കിൽ പോലും നമ്മുടെ സർവീസ് എക്സ്റ്റെൻഡ് ചെയ്യുന്ന ഒരു രീതിയാണ് HMAക്കുള്ളത്. അത് ഞാൻ ഒന്ന് ഇതാക്കുകയാണ്. ഇവിടെ 5 വർഷത്തേക്കുള്ള ലൈസൻസ് എല്ലാവരും എടുത്തു വെക്കണം. അത് നമ്മുടെ പ്രിവിലേജ് ആണ്. ആ പ്രിവിലേജ് നമ്മൾ കളയരുത്. ആരെങ്കിലും അങ്ങനെ എന്തെങ്കിലും, പിന്നെ അനധികൃതമായ ഇൻസ്പെക്ഷൻസ് ഉണ്ടെങ്കിൽ അതിന് വേണ്ടുന്ന പ്രോട്ടോകോൾ, ഒരു വിദേശിയായിട്ടുള്ള ആരെങ്കിലും അഡ്മിറ്റ് ചെയ്യുന്നുണ്ടെങ്കിൽ അതിന് എന്തൊക്കെ വേണമെന്ന് ഗൈഡ് ലൈൻ ഉണ്ട്, HMA ഗൈഡ് ലൈൻ ഉണ്ട്. അത്തരം കാര്യങ്ങൾ നിങ്ങൾ മനസ്സിലാക്കാൻ നിങ്ങളുടെ ഭാഗത്തുനിന്നും കൂടി ഒരു ഇനീഷ്യേഷൻ ഉണ്ടാവണമെന്ന് മാത്രം പറയുന്നു.